starting with the extremities, I'll expose your legs, alright? So exposing patient's leg areas. So for this demonstration, I'll be performing on the right side, but in real life, I'll be doing it in both side of the patient and do compare. And then do a comparison. Yes, thank you. And then I already checked my patient's vital signs, especially the BP and the pulse rate, and it is within normal limits. Now inspecting. Inspect first. The patient's skin color is appropriate to ethnic background, no signs of ecchymosis, erythema, bruises, cyanosis, or skin breakdown noted. Hair is evenly distributed. Okay. No signs of edema, no signs of clubbing of the fingers noted. Venous pattern is flat and barely visible. No signs of varicose veins noted. Ano ba yun yung nakikita? Ano bang tawag?
Varicose.
Hindi, yung sa lumps mass. No visible lumps or
Venous
mass
pattern.
noted. So, now I'll be palpating your legs and your arms. Okay? So, ito lang yan. Warm my hands for at least 30 seconds, starting at the right foot. Kindly tell me if you feel any pain or discomfort when I palpate your legs, okay? Any discomfort? Okay, perfect.
Ayun, tama.
Any discomfort or pain? No? Okay, no tenderness, no lumps, no mass noted. If you notice a mass, you need to note the location and the size of it. And then, okay, skin is warm to touch, not dry, not too moist. Now, checking for pretibial edema. Pressing for 5 seconds. No indentation noted. So, if you notice edema, we need to grade it from 1+ to 4+. Check for capillary refill. Okay, capillary refill is less than 2 seconds. Indicates good tissue perfusion. Now, I'll be checking for your pulses, okay? When checking for pulses, I need to note the rate. It should be 60 to 100 beats per minute with a regular rhythm and 2 + 4s. Starting at the dorsalis pedis, lateral and parallel to the extensor tendon of the big toe. Okay. Posterior tibialis at the groove between the malleolus and the Achilles tendon. Okay. Next is popliteal. So, kindly relax your knees for me, please. Okay, perfect. So, checking for the popliteal fossa in the medial tendon. Okay, good. Now, we'll be checking for the femoral artery. Hindi ka papalwig. Kindly abduct your thigh for me a little bit. Okay, perfect. So, when checking for
Touch
the
na yan.
femoral artery, for this demonstration, I'll be doing it over the clothing, but in real life, I need to do it on the skin. So, it is located at the in between syphilis pubis and iliac anterior superior iliac spine. Okay, perfect. Now, I'll be checking for your extremities, for your hands. Can you tell me if you feel any discomfort or pain, okay? Any discomfort or pain? No? No? Okay, perfect. So, no mass, lumps, and no tenderness noted. Skin is warm to touch, not dry, not too moist. Good skin turgor, no signs of dehydration noted. Okay, capillary refill is good, less than 2 seconds. Good tissue perfusion noted. Ano pa ba? Now, checking for pulse. At the biceps brachii, medial tendon of the biceps brachii muscles. Okay, next is the radial at the lateral tendon of the flexor carpi radialis muscle for 30 seconds. For example, 30 seconds na. So, patient's pulse rate is 80 beats per minute with a regular rhythm and 2 + 4s, which is good and normal. Now, I'm done with your extremities. I'll be covering you up. Okay. I'll be positioning you to sitting position, or can you sit down? Is it okay? Are you alright? Any dizziness? Can you dangle your feet here? Comfortable with that position? Okay, so, dito na ito.
Daming video ah.
Kaya, artista? Okay, first is palpation of the carotid artery. When palpating the carotid artery, again, we need to do it one at a time because it will cause, we will cause fainting to the patient because if we press it at the same time, it will cause a decreased oxygenation into the brain, and then avoid palpating it too hard or putting too much pressure and massaging the area because it will stimulate the vasovagal, causing the heart to decrease, the heart rate to drop, and then the um, blood pressure also to drop, causing again fainting to the patient. So when checking for the carotid artery, we need to take note of the contour and the amplitude. It is located between the trachea and the sternomastoid muscle. Okay, so the contour is smooth with rapid upstroke and slower downstroke with a regular rhythm, 2 plus force and bilaterally, same bilaterally. Now I'll be auscultating your neck area, okay? So auscultating the neck area, we need to take note of the three locations: the angle of the jaw, mid-cervical, and the base of the neck. Again, avoiding to put too much pressure because it will create a false brewy sound. So in the auscultation, we need to assess for the brewy, which is a blowing, swishing sound due to narrowing of the carotid artery. So you can hear it if it is 1/2 to 2/3 occluded. If it is less than 50% or more than 60%, it is more quieter, or you cannot notice the brewy. But if you are in doubt, you can do additional tests like Doppler ultrasound of the neck. So, when you feel or when I assess your neck area, kindly fully take a deep breath and then exhale and then hold your breath for me, okay? Inhale, exhale, hold. Okay, no brewy noted to the patient. Kindly take a deep breath now. We're done. No brewy noted to the patient. Any dizziness or okay? Perfect. Next, ano na ba? No brewy noted. Patient done. I just want you to lie down on the bed again. Please. Sorry. Gusto kong unahin ng JBP bago ko sana paupuin eh.
Para minsanan ka.
Para minsanan
Baka
sana.
pwede yun, di ba?
Hindi pwede.
Hindi pwede.
Hindi pwede.
Hindi daw? Ito sa totoong buhay, una
Kasi
naman dapat talaga ang
naglagay
JVP
talaga siya ng
eh.
naglagay talaga siya ng sequence niya eh.
Oo. So, I'll be adjusting the height of the head of the bed to 30 or 45 degrees angle. Can I remove the pillow? So, the neck of the patient should be in a neutral position, not flexing and hyperextending. We need to, can you please look on your left side for me, please? Check for when checking for jugular vein pressure, we need to take note or to assess the maximal impulse of the internal jugular vein. It is more reliable when checking for the internal jugular vein because it is directly attached to the superior vena cava and is reliable on the right side because of the anatomical position of the right atrium. But in real life, you can do it on both sides. But it's better to assess on the right side of the patient. So when checking for JVP, we can use 2 rulers. One vertical at the angle of Louis or sternal notch of the patient's sternal border angle. Then parallel or horizontally the other ruler on the point of maximal impulse during exhalation because there is an increased pressure in the thoracic cavity of the patient. So, patient, so we need to look at it for eye level. You can use pen light if you want so that you can assess it or you can see it more clearly. And then, the JVP of patient is 3 centimeter at the sternal angle with the patient lying at the 45 degrees angle. Check also for any distension of the external jugular vein. No distension noted. So if you notice any unilateral distension, it indicates aneurysm. And it is fully dilated. It is due to or increased central venous pressure to the patient. So we're done with you. Now, we're going to Chester. We're going to Chester. So Chester, again, when checking for the precordial area of the patient should be at a 30 or 45 degree angle. First is inspection. Thorax is symmetrical and elliptical in shape with the ribs sloping downward. No signs of pectus carinatum excavatum noted. No retractions and bulging noted during inspiration. AP diameter to transverse diameter is 1:2. No signs of barrel chest noted. Skin color is appropriate to ethnic background, no cyanosis, no pallor, no bruises, no erythema noted, no skin breakdown noted to the patient, no signs of surgical lesion noted also.
Excavatum.
Hair is evenly distributed. Now I'll be checking for the
Excavatum
presence
carinatum.
of hives or lifts. Hives is a due to the forceful thrusting of the ventricles, causing a vigorous movement in the chest wall of the patient.
Nag-stop ako.
So, if you notice hives on the left sternal border, it is due to right ventricular hypertrophy. And if it is near to the apex, it is due to left ventricular hypertrophy. You can also check for the apical pulse or apical impulse of the fifth intercostal space mid-clavicular line. It is noticeable in patients who are skinny, but hard to notice in patients who are obese or muscular, heavily muscular patient. You may or may not see this. So next, we need to move on to palpation. You need to warm your hands for at least 30 seconds. So Chester, I will now palpate your chest area. Kindly tell me if you feel any discomfort or pain. Any pain or discomfort? Okay, perfect. No tenderness, no lumps, no mass noted. Again, if you notice a mass, you need to document the location and the size of it.
Nag-uwi ako.
Next is
Bumalik lang ako.
skin is warm to touch, not dry, not too moist. Good skin turgor, no signs of dehydration noted. Checking for apical pulse at the fifth intercostal space, mid-clavicular line. 1 or 2 fingers is okay. Checking for the size, 1:2 or 1/2 centimeters. Amplitude is short duration, occupies the first half of systole, and the amplitude is a gentle tap. So in patients with cardiomegaly, it is located or displays lower and more on the left side of the patient. And if patient has hyper or pulmonary emphysema, you cannot assess the apical pulse because of the hyperinflation of the lungs. So if you are having hard time to check it, you can ask also the patient to turn on his or her left side so that the heart is near to the chest wall. Okay, good. Next is checking for lifts. So lifts is our trills, I should say. Trills is a palpable vibration that can be felt in the hands, and it is described as a throat of a purring cat. Checking for the base of the heart, the sternal border, and the apex. Second intercostal space, right side. Second intercostal space, left side. Sternal border, then the apex. Okay, no trills noted. If you note a trills on the left side or right side, second intercostal space, it is due to aortic stenosis or systemic hypertension. And if it is in the left side, it is due to pulmonic stenosis or pulmonary hypertension. Next is palpation, auscultation. So I'll be checking for 5 locations. Aortic valve is located at the second intercostal space. Pulmonic valve located at second intercostal space, left side. Left sternal border, third intercostal space, where the Erb's point is located. And then mitral tricuspid valve at the lower sternal border, fifth intercostal space. Then mitral valve located at the fifth intercostal space, mid-clavicular line. So disinfect. First, we need to use the diaphragm of the stethoscope, and then next is the bell. patient to turn on the left side to check for murmur. Good. When checking or auscultating the patient, we need to take note of the rate, the rhythm, the presence of the S1 and S2, and the presence of extra heart sounds or the S3 and S4, and presence of a murmur. If you notice a murmur, you need to take note the quality, the pitch, the location, the duration, the loudness of the murmur. So now we're done with auscultation. Checking for aortic and pulmonic regurgitation. Position the patient on a 90-degree angle using the diaphragm. It is located at the right second intercostal space and in the left second intercostal space. Ask the patient to lean forward and then exhale. Okay, exhale. Good. So no aortic regurgitation noted to the patient, which is normal. Lastly, we need to do percussion, starting at the anterior axillary line, 5th intercostal space, and we need to take note for any changes in the sound, or take note of the dullness while moving towards to the 5th intercostal space, midclavicular line. We are doing this to outline the borders of the heart. But if you notice that there's any signs of cardiomegaly, we can do a definitive test like chest x-ray and echocardiogram. So that ends my demo.